All right, good evening, everyone. My name is Dr. Douglas Miller. I'm an orthopedic surgeon and hip and knee specialist at OSMS in Green Bay, as well as the Fox Valley. Sorry for the technical delays. We had some difficulty getting the live stream going, so hopefully you can all hear me. Tonight, our topic of discussion is going to be hip and knee arthritis, as well as treatment options, both conservative as well as surgical treatment options, including hip and knee replacement. So in general, I want to start off just by telling you a little bit about myself. I grew up in Eastern Pennsylvania, did a lot of my medical training, both medical school and residency in Chicago, and ended up doing my hip and knee replacement fellowship at the Baylor College of Medicine in Houston, Texas. So from there, I came up to the Fox Valley and started my career with ThedaCare, but inevitably ended up joining OSMS a year and a half ago as their hip and knee replacement specialist. So with that being said, tonight our discussion is going to center around hip and knee replacement and hip and knee arthritis like we talked about. I'm going to start just by giving you a general overview of what exactly hip and knee arthritis is and the diagnoses that we certainly have. And then we'll get into discussing treatment options going forward, including surgical and conservative treatment options. So with that being said, in general, hip and knee arthritis or osteoarthritis is, in layman's terms, essential just wear and tear of your joints. So as you age, the cartilage in your hip and knee joints gets more fragile and it tends to wear out over time. It's due to a multitude of factors, including weight, activity, genetics, previous surgery, amongst other things. So treatment options for hip and knee arthritis, we usually start pretty conservatively depending on where you're at in your treatment realm. In general, we start with activity modification. So if you're starting to just have a little bit of knee or hip pain, the first thing you want to be doing on your own is looking at what you're doing on a daily basis. A lot of people are into vigorous activities or activities that include hiking and climbing, squatting and kneeling. All those activities tend to put a lot of excess pressure across your hip and knee joints, and that can actually lead to early wear due to the increased stress. So the first thing you want to look at is activity modification, and the things to really avoid are stairs, kneeling, squatting and bending, as well as repetitive pounding exercises. So I usually tell patients you want to avoid anything that's going to make your joint hurt by repetitive motions, because every time that hip or knee goes through a cycle of constant stress, it's putting a lot of stress across that cartilage and can lead to early wearing out. So as far as activity modification, the things you can be doing to change the way you exercise and the way you live your life with hip and knee arthritis, you want to avoid those high impact exercises, but swimming, bicycling, elliptical machines, and even walking on a treadmill are all good for your joints, as they limit the amount of stress that is being impacted across those hip and knee joints. So when we talk about when activity modification doesn't work, we start looking at other factors of what you can be doing. Most people want to work on weight loss, no matter if you're a couple pounds overweight or more overweight than you want to be. Any amount of weight loss that you can achieve will certainly take a lot of stress off your hip and knee joints, up to 5 to 7 times your body weight. So think of it as even losing 10 pounds, your hip and knees are going to feel like they're losing anywhere from 50 to 70 pounds. And that can make your joints overall feel a lot better. So once we get into the realm of activities aren't being modified and working, or your weight loss isn't working, really what we get into is we got to start looking at medical treatments. So routinely, before you probably even see an orthopedic surgeon for your hip and knee pain, it's a good idea to start on an over-the-counter anti-inflammatory if you can safely take it. Ibuprofen, Aleve, amongst other ones, are readily available. Tylenol does work. It doesn't help with the inflammatory nature of the arthritis, but it can certainly help relieve some of your pain. When we start crossing into the realm of the oral medications aren't working, we don't like to treat hip and knee arthritis with narcotic medication. And usually when you're needing a pain medication or something stronger than the ibuprofen, the Aleve, and the Tylenol, we're probably at the point where we're discussing surgical treatment options. And routinely, we aren't prescribing pain medication for the treatment of hip and knee arthritis. So the next steps then kind of fall into more invasive injections. The gold standard is usually a cortisone injection. What that does is when it interacts inside your knee joint, it helps reduce the inflammation in the synovial or the lining of the knee joint, as well as any inflammation in those large joints that could be causing a lot of your pain. They are usually effective, but can vary from patient to patient. Not everybody responds the same way to the cortisone injections. With that being said, that's kind of our frontline treatment from a more invasive standpoint. So usually if you're at the point where you're having a recommendation for a cortisone injection, you're in pretty significant pain and debilitation. So there are other types of injections. There's some more longer acting steroid injections that we try. Another one that you may commonly see is the quote gel injections, which in our world is a viscosupplementation. And usually there's multiple series of these and different types of them. But in general, the viscosupplementation is available for what would be called a lubrication for your knee joint, to get in between those arthritic surfaces and really, essentially, I call it's motor oil or WD-40 for your joints, to just get a barrier between those arthritic surfaces to help your joints glide a little bit better without causing significant pain and debilitation. Now, those aren't readily available for or even approved for hip injections, but they are routinely available for knee osteoarthritis and approved for injections for your knees. As far as supplementations and things that you can be trying on your own, there aren't a lot of great supplements that have been shown in the literature to be very effective at limiting or preventing the progression of your knee or hip osteoarthritis. One that is very effective that has shown some pretty strong results is prescription brand turmeric. It is a strong natural anti-inflammatory, and that has shown to have positive results on limiting some of the pain and inflammation in your joints. There are certain supplements like chondroitin sulfate or glucosamine, which have in the past been used. These have kind of been shown to not have a very significant effect on your overall pain or the progression of your hip or knee arthritis. So routinely, I don't recommend those, but it's one of those situations that if you think that if you think it's affecting and helping your hip or knee pain, then I would just continue on it. When we get to the point where your injections aren't working for your hip or knee arthritis, we start to slide into that realm of surgical treatment options. Certainly, there are hundreds of thousands of people every year getting to the point where they're in discussions with hip and knee replacement with their orthopedic surgeon. Hip and knee replacement is a very powerful and strong procedure to really effectively, almost instantaneously, relieve your hip and knee pain. So I'm going to go a little bit into what actually entails hip and knee replacement, and I have some models to show you as far as what they are. We'll start with knee replacement. In general, there's 4 parts to a knee replacement. What we are in general doing is we're resurfacing your knee. So we're shaving off the bad cartilage and a little bit of bone in order to resurface it with cemented components, which will recreate your knee joints. So if you look at this model here, they come in 4 parts. There's a femoral component, which is the top part here. That is made out of cobalt chromium metal, and that is through specific bony cuts and technology. We actually cement that onto the knee replacement and can certainly, if the model works, be able to effectively cement on a femur component, which will hopefully be bonded with you for life. On the bottom side is a metal tibial tray with a keel that gives us rotational stability for the tibia component. And again, that is made out of, in most implants, titanium, and that can be cemented onto your tibia bone. In the middle, the tan piece is actually a polyethylene liner, which has been highly cross-linked to prevent significant wear. But as you can see, that's your modular bearing for your knee replacement, and that's what allows your knee to move and glide effectively pain-free once you recover from your surgery. So what you can't see here is on the back side of the kneecap, we actually resurface it and cement on a button, and that allows your kneecap to track appropriately in the groove of the femur. So what you have is a component and construct which allows your knee to bend, move, and glide so that you can essentially eliminate your pain, because this is an inert substance with the metal and plastic construct, and allow you to function and do the things you want to do on a daily basis without being limited by the arthritic knee pain. So knee replacement and surgery and hip replacement surgery, they do differ in the recovery times. Usually, I tell my patients it's a little bit easier to recover from a hip replacement than it is a knee replacement. I usually describe two phases of recovery. There's the initial wound healing phase, which is around 2 to 3 weeks. As long as your wound heals up, then we transition you into a more aggressive recovery or rehabilitation phase. That's when we really get you into physical therapy and get your knee bending and straightening so that you can have full range of motion. And in that same time, we're building up your strength to allow you to start ambulating longer distances, navigate going up and down stairs, as well as eventually getting into an exercise program at home so that you can function daily with your new knee replacement. Usually that process can take up to 3 months, and certainly for certain individuals, it can take a lot longer depending on how strong you are going into surgery, how bad your knee replacement was to put in, and how bad your knee arthritis and range of motion was before surgery. So the results can vary as far as how long it takes to get there, but certainly by 1 year, you should be living relatively pain-free with your new knee replacement. On top of initial knee replacement surgery, I do a lot of revision hip and knee replacement surgery. I know there were some questions that came through with regards to that. When we get into revision knee replacement discussions in the office, usually I will wait up to 1 year following your knee replacement to even begin having those discussions, as it can take that full year for your knee to heal. If you're living with a new knee replacement, or even a knee replacement that's 10, 20 plus years old, and it is causing you daily pain and swelling, when that gets to a point where it's affecting your quality of life and your ability to ambulate and walk and even move, that's time to come in and get seen by an orthopedic surgeon to evaluate your painful total joint. Now, with regards to knee replacement surgery, these things aren't foolproof, and knee replacements do fail, and they fail for a variety of reasons. And the most common one is infection, and obviously the first thing we always do with looking at a painful knee replacement is ruling out infection. If there are no signs of infection, the next step is to look at other sources of why your knee could be causing pain. You know, my job as a hip and knee replacement specialist is to rule out and make sure there are no causes of your knee pain that could be catastrophic to the deterioration of your knee replacement. Sometimes the cement and the implant can get loose from the bone or the metal, and that would be called what's called aseptic loosening. And if that's the case, usually you have a lot of pain with startup and ambulation, a lot of activity related pain, and pain that's pretty much throughout your day while you're active. So we look at x-rays to really evaluate whether there's new lines and areas where it looks like it's debonding from the bone or the cement. And we can usually pick that up on x-rays and sometimes need a confirmatory bone scan. Other reasons why you could be having knee pain after your knee replacement surgery would include instability. And instability in general is your knee has become lax. And when your knee becomes lax, there's a lot of micro motion through your knee replacement, which can really anger and make inflame the tissues and ligaments around the knee. Usually unstable knees, or knees that are getting, quote, wobbly, tend to present with recurrent pain, recurrent swelling of the knee that otherwise doesn't look infected. So if the knee does appear unstable and it's affecting your ability to function and ambulate, that is an indication for knee replacement surgery, or revision knee replacement surgery, excuse me. And there are other, obviously, less common reasons these fail. Sometimes you can have malposition of the components on the way they're put in. Sometimes your kneecap can be subluxing or shifting and then even dislocating. And there are some more rare causes like allergies to the nickel in the metal, which is very uncommon, but can happen in certain individuals. So I'm going to transition to talking a little bit about hip replacement surgery and revision hip replacement surgery, and then we can kind of swap out and transition to doing a question and answer session afterwards. So in general, the treatment of hip and knee osteoarthritis is usually the same when it comes to conservative management. The injections into the hip joint for osteoarthritis are a little bit less common, and we don't do them as frequently. But there are ways to do ultrasound guided hip injections or X-ray guided hip injections to ensure that we're getting the steroid into the joint to effectively calm down your pain. But if we get to a point where your hip pain is very debilitating and again affecting your quality of life, and you have advanced or end stage osteoarthritis, hip replacement surgery is a very successful option as far as treating your hip and knee pain. So hip replacement surgery in general does the same thing that knee replacement surgery does. This is just a model of the pelvis, but you can kind of see based on the model what a hip replacement is. So in general, the hip replacement consists of 4 parts. The first thing we do is we core out your socket, or what's called your acetabulum of your pelvis, and we don't cement these in, we what's called press fit these in so that your bone captures around it and gives us good initial fixation. Now, we don't use cement routinely in hip replacement surgery. If you can see closely, there is porous coating on the back of these implants, which biologically integrates into your bone. That process can take up to 3 months, but once the implants integrate into your bone, they're more than likely with you for life unless something fails. The next piece we snap into place is a polyethylene liner, and that acts as half of your bearing for the hip replacement. And then we switch to the femoral side of things, and obviously this is a clear model, but this would represent your femur bone, and this would be your femoral stem, and there are a variety of stems that we use to instrument the femur, but the concept is the same. This is made of some porous coating on a titanium stem, which when that gets instrumented into your femur through that same press fit technique, which gives us good initial fixation, over 3 months that will biologically ingrow into your bone. Once that ingrows into your bone, same as the socket side, it's likely there for life unless something fails. Now there is what's called a modular component to this, and what we do is onto a taper we impact in a head, and these heads can come in ceramic sizes or ceramic or even metal, and that impacts into place and that gets stuck on the femoral component, and then we reduce your hip. So as you can see, it allows your hip to move and shift around without pain because, again, we are using metal and plastic inert objects to reconstruct your hip joint. So this will take care of all that arthritic surfaces and the bone spurs around your socket, which were normally causing you pain. The goal is that we free up your range of motion and give you a stable hip that's going to allow you to ambulate almost instantaneously after surgery and start in your recovery rather quickly. So if you do some Googling, and certainly with joint replacement surgery, there's a lot on the internet out there, but a lot of questions will come up about which way is best to go into the hip, which type of implants are best, and we can answer some of those questions for you tonight. There are multiple ways or approaches into the hip joint. There's about 4 mainstay ones, and they've all been around for quite some time. There's a lot of popularity in the anterior hip replacement recently, and as well as the posterior hip replacement, which is kind of the workhorse approach to hip replacement surgery for quite some time. So with posterior hip replacement, you go through the back of the hip, so your incision's kind of laying over your buttocks. It's not a muscle sparing approach, so you do go through the muscle of the gluteus or the butt muscles, and we just get into the hip through the back of the hip, and that's just one approach in. I do both anterior and posterior hip replacements, but I do the majority of mine through the anterior approach. The benefits of the posterior approach and the anterior approach at about 6 months post-operatively outweigh each other, and the outcomes are usually similar. With the posterior approach, you do have to worry about popping the hip out and dislocating the hip, which is a common complication. Really, you just want to avoid flexing or bending your hip up to 90 degrees and rotating or internally rotating your leg towards your other knee, and that puts you at higher risk for dislocation. I prefer to do the anterior approach because that dislocation risk is lower, and also you don't have to worry about hip precautions as much. The anterior approach is becoming more and more popular because a lot of literature has shown that the early functional outcomes and recovery in that first 6-week period are a lot quicker than the posterior hip replacement. So both approaches accomplish the same thing as far as getting your implants in and your hip replacement into your body. But the anterior approach does it through a muscle sparing approach. So we go in through an incision through the front of the hip. It's minimally invasive, and it's also muscle sparing, meaning that we go around the muscles and we don't actually cut through the muscles. We get down to the hip and we put in the hip replacement the same way we would with a posterior hip. Really, I prefer doing these through an anterior approach as long as you are a good candidate, mainly because I think your early recovery is fairly quick. But the anterior approach is not made for everybody, and certainly there are criteria that I have in selecting who's best for an anterior approach. Usually it's younger, lower body mass index individuals. A lot of it depends on the type of or degree of arthritis you have and how severe any bony deformities are. So we look at the entire patient when selecting who is right for an anterior total hip replacement. But in general, both achieve the same eventual outcome, which is a stable hip replacement that's allowing you to ambulate, function, and restore your quality of life without the pain of the hip osteoarthritis. Just as we discussed with the knee replacements, these hip replacements can fail and there are certain complications. Again, aseptic loosening, meaning that the implants can debond or get loose from your bone. If that happens, that would be an indication for revision hip replacement surgery. Dislocation, I mentioned, that can happen, meaning that the ball actually pops out of the socket and you're not able to ambulate or bear weight, and usually ending up in the emergency room to have that fixed. So infection is another one. Just as it's the #1 cause of revision surgery and knee replacement, it's the #1 cause of revision surgery and hip replacement, and certainly is fairly common. There are other less common complications or needs for revision surgery after hip replacement. One you will certainly find on the internet would be metal on metal implants, which are becoming a thing of the past. Those metal on metal implants can actually create what's called metal ion disease inside your hip joint, which can set off a inflammatory reaction, which can actually damage the tissues and tendons around the joint and create actual metal toxicity throughout your bloodstream. So that's why we are very concerned when we see these implants, and we routinely check metal ion levels to ensure that these are not getting in your bloodstream and causing some systemic toxicity. So if you have a painful hip replacement and it's a metal on metal articulation or bearing, that's something that you would want to get checked out and have somebody monitor pretty closely. But in general, I think what we're seeing as a trend across the country is hip and knee replacement surgery is becoming more and more popular for a variety of factors. A lot of America's obesity epidemic is achieving that. We are also a more younger active population, that are certainly wearing out their joints a lot sooner than we had wanted to. We are doing more and more hip and knee replacements, I think, more than ever now on younger individuals that are just having, their joints wear out at a relatively younger age, even into their 40s. Routinely, when we're deciding whether to go forward with hip replacement or knee replacement surgery, we want to maximize the amount of time before and age before getting to the point of recommending hip or knee replacement surgery. And mainly that's because these implants do have shelf lives and they're not going to last forever. Depending on your activity level, it could be anywhere to 20, even 30 years. Obviously, higher demand and higher activity, individuals will tend to wear these joints out a little bit quicker. Usually I use the analogy of think about your engine in your car. If you're running your engine at 3,000 RPMs versus 6,000 RPMs, the higher RPM engine is going to wear out a lot quicker. So this is why we routinely follow you through the postoperative process, usually every 3 to 5 years with surveillance x-rays to make sure that nothing is failing. But with the increasing numbers and anticipated numbers of hip and knee replacement surgery over the next decade, rising in the United States, certainly a lot of these questions are becoming more and more common, and so is the hip and knee replacement surgery. So with that being said, that was just a really quick general overview of hip and knee replacement surgery as well as revision hip and knee replacement surgery. I'm going to open it up at this point to questions, and certainly some have been submitted already, and I will start addressing those. But as any questions come in live, we will certainly be able to answer those as they come through. So with that being said, just give me 1 minute to pull up the questions and I'll be right back with you. All right, bear with me. I am doing this from my cell phone due to some technical difficulties, so I will try to get your questions as they pop through the feed. But I will also start with the questions that came up from submission to our website. So a very common question, especially during COVID-19 and the pandemic, is what are we doing as far as, at least at our facilities at OSMS, to keep patients safe, but also able to certainly get them through surgery safely without exposing them to COVID-19 or any illness. So amongst other things, we're doing the routine stuff that everybody's doing at most medical facilities with temperature checks and screening. We do preoperative COVID-19 testing before you would be able to step into the facility with a negative test. A difficult one for patients is we are unfortunately having to limit family members, but that's for everybody's safety, to limit traffic in and out of our surgery centers as well as the hospital. We are certainly cleaning, sanitizing, and disinfecting all surfaces, as well as maintaining social distancing to safely be able to get you through surgery. So, with the pandemic, we certainly had a lot of patients that are a little hesitant to come in for surgery, but we've done a very effective and excellent job at being able to treat patients safely and get them through their joint replacement or any other orthopedic surgery at our surgery centers by following a lot of these modalities. without exposing them to significant risk for COVID-19 infection. So another question would be, we kind of discussed anterior and posterior hip replacement surgery. How does rheumatoid arthritis impact joint replacement surgery? This is always a good question. Obviously, at OSMS, we have multiple rheumatologists and providers that we work closely with in treating hip, knee, and even other joint pain. As far as how does rheumatoid arthritis affect your hip and knee replacement surgery, in general, rheumatoid arthritis is it's a disease and inflammation of the lining of the synovium, or what's the internal lining of your joint. The tissues tend to be very inflamed with a rheumatoid arthritic hip or knee. The bone quality also tends to be a little bit softer. So those are all things we take into consideration when doing your hip and knee replacement surgery to ensure that there's no fractures or any deterioration of your bone. Doing hip replacement and knee replacement surgery on somebody with rheumatoid arthritis also oftentimes requires taking you off certain medications that you're on for your rheumatoid arthritis and some of your IV infusions. And we have certain protocols based on what medication it is to make sure that you're off those medications leading into your joint replacement surgery to ensure that you're not being at higher risk for infection. Another question that came in is, what is the typical recovery period for a partial knee replacement? That's one thing I didn't mention beforehand, but I do partial knee replacements, both patellofemoral as well as medial and lateral unicompartmental knee arthroplasties. The indications for partial knee replacement are very strict, and certainly I can go over those with you in the office, but the recovery for partial knee replacements is a little bit quicker than a total knee replacement, usually early on, mainly because there's less pain, limited blood loss, as well as a more minimally invasive incision. Usually by 4 to 6 weeks after partial knee replacement, you're doing quite well, but that recovery can extend up to 3 months to even a year, just like a total knee replacement. Another question came in that, what are limitations after a partial knee replacement compared to a total knee replacement? That's a good question to discuss as that comes up a lot. Common limitations are that during your exercise and eventual recovery, we want to avoid high impact type exercises. So we try to recommend less impacted exercises as well as more gravity-free exercises. But in general, even after partial or total knee replacement, you want to avoid kneeling. That tends to be a problem for a lot of patients, but it can, in a total knee replacement, wear out the joint behind the kneecap, whereas in a partial knee replacement, it could irritate your incision or even cause further arthritis behind your kneecap. But in general, you just want to avoid high impact exercises and things that could potentially loosen the partial knee replacement as well as the total knee replacement. With a partial knee replacement, you got to keep in mind that you still have cartilage left in your knee, and we want to preserve that as much as possible. So again, by limiting your exercises to more gravity-free or less impaction exercises, certainly that can give you the best possible outcome. I just saw one question come in that I'll address right now just because I saw it. Regarding somebody who asked if they're having their first knee replacement done, whether it can be done at the surgery center or at the hospital, and certainly that's a great question at this point. A lot of hip replacement and knee replacement surgery is transitioning to a more outpatient and ambulatory surgery setting, as long as it can be deemed safe. Certainly, there's a lot of selection criteria that go into picking who is a good candidate for an outpatient or even a surgery center total joint replacement. A lot of that comes down to, what are your medical comorbidities? Do you have cardiac and significant respiratory risk factors? Usually those patients that are higher risk will be done at the hospital so that we have the support of all the ancillary hospital services should we need them. Usually patients that can get their surgeries done and joint replacements done at the surgery center are younger, healthier, medically very active, have good strength going into their surgery so that their recovery can be a little bit quicker. But certainly at OSMS, we have the capacity with 2 surgery centers to fully perform total hip and total knee replacement, as well as some commercial total shoulder replacements at our surgery centers, and be able to effectively allow you to stay overnight. You get therapy and one-on-one nursing services, which will help you coach you through your initial evening with your new joint replacement, and certainly get you to a point where you're safe to discharge home the next day. And another question that came through, if cortisone hasn't helped me with pain, are there other options beside knee replacement? And would those be temporary? And eventually would I need knee replacement surgery? So that's a good question as well. One point I didn't touch on earlier with regards to how do you stave off or prevent knee replacement surgery. There are other types of injections outside of the cortisone and the viscosupplementation injections. A newer one that has been being performed in certain individuals is PRP, or platelet-rich plasma injections. We certainly have the capability to do those within our offices. The literature is starting to come out a little bit more positively for PRP injections, but routinely when you have advanced arthritis, I do not think that a PRP injection would be worth the time and money to effectively treat your arthritis, as when your arthritic disease is that far along, I don't think that the PRP will be effective when you have a completely destroyed knee or hip replacement. There are some people probably asking about stem cell injections. We are very early on in studying the effects of stem cell injections on hip and knee arthritis. Certainly there's some promising initial data that's showing that it could be effective, but I just don't think we're quite there yet to be routinely offering these to patients, as they are expensive and hard to predict when or if they will work. Are there any other questions or anything that I didn't address? I think I got most of the questions that were submitted ahead of time. If I missed one through the live feed, we can go ahead and resubmit those, or you can go ahead and ask them. I'd be happy to answer any further questions at this point. And I just saw Karen just submitted a question that I must have missed before, so I apologize for that. Another great question: do we do both knees at once? So in our world, that's called bilateral knee replacement, so both knees at the same time. Certainly that can be done, and it can be effective if done appropriately, but there are certain risks. As you can imagine, there's certain risks with just doing a knee replacement at one time, and usually those risks are infection, blood loss, blood clots, as well as any further medical complications that could arise. In general, with bilateral or both knees at once knee replacement, those risks tend to double. And there is more and more literature coming out that supports that the risks do double with bilateral knee replacements, and you can certainly struggle from those. Routinely, if a patient can wait, I will recommend staging them at least 6 weeks apart. By 3 months after staged bilateral knee replacement, I think they're doing equally as well as they would be doing with bilateral or both knees at the same time. With that being said, I will consider it if a unique situation exists with work or trying to get back. But certainly, the patient comes first, and putting them at double the risk of a single knee replacement, to me, is routinely not worth it. And I think we can get the same result by staging them 6 weeks apart. I think Jan just had a good question. What about being overweight and needing total joint replacements? This is a great question, one that almost comes up daily for orthopedic surgeons. there is a significant connection between higher body mass index or higher weight and increased complications and infection risk. So routinely, a BMI or body mass index of 40 is kind of the cutoff where your infection risk starts to climb exponentially. So the higher body mass index you are, or the higher weight you have, you are at higher risk of infection, early loosening of the implants, as well as other complications. So routinely, we're not recommending joint replacement surgery, and every surgeon is specific as far as what body mass index they are comfortable with, and that's a question to have with your surgeon that you are discussing joint replacement surgery for. But otherwise, a really good question. Connie just sent a message that said, what can someone do physically ahead of total knee replacement to ensure the most smooth recovery? Again, this is a great question, and one I really harp on with my patients. I really stress prehabilitation exercises. So we give you those when you schedule your surgery for you to be working on in the weeks leading up to surgery. And what usually that entails is strengthening the muscles around your knee and hip to ensure that your muscle tone and your strength is at a point so that your recovery is a lot smoother and quicker. I usually say that if you don't do those, you're kind of starting at the bottom of the mountain. If you do those exercises and do your prehab, you're starting halfway up that mountain already. So getting to the peak is a lot quicker than if you started at the base. So routinely during your initial coaching and your total joint replacement class, we are stressing the importance of the prehabilitation exercises, and it would be in everybody's best interest to do those leading up to surgery. Another question that came in is, what is the effectiveness or even percentage effectiveness of gel injections? Routinely, cortisone injections are a lot more effective in treating your pain. Routinely, that is because you are treating the inflammation, and the inflammation is what causes the pain inside your joint. So cortisone injections are effective. And like I said, gel injections I think are a little bit less effective, and it's hard to put an actual percentage on it. But with that being said, I usually tell patients it could be in that 50-50 round. I don't like injecting patients, excuse me, and seeing them come back after a gel injection with pain 2 weeks later. So with them being gel injections, it depends on how arthritic your knee is. A bone-on-bone knee, I usually don't even recommend gel injections because it's very hard to get that lubricant in between those arthritic surfaces. Usually I'll save those injections for patients with maybe 50% narrowing of their joint space, where we can get some gel in between the cartilaginous surfaces and give them some relief of pain. Looks like Michelle asked, why do they not recommend doing a knee replacement till at least 45? This is a great question, as you know, like I said, the American population and even across the world, we're just becoming more active in our younger ages, and that's leading to early degradation of your joints. There's certainly other pathologies like avascular necrosis or dead bone disease, or dysplasia, which is just the way your hip was formed at birth, which can predispose you to early arthritic disease, as well as previous surgery on your hip or even traumatic injuries. So I don't really set an age range as far as who can get a knee or hip replacement. What I do is I look at the whole picture and make sure that that patient is able to live the life that they want to. We want to wait as long as physically possible before going ahead with knee or hip replacement surgery, because like I said, these implants have a shelf life. They're not meant to last 50 years, and they likely won't, and they will fail by one of the means we discussed previously. But if we can get you to 45, 50, and delay joint replacement surgery as long as possible and keep your pain under control, then certainly we'll try to do that. But there are times in younger individuals where we get to a point where we have to look at what is their quality of life, how much pain are they in, are they gaining weight, are they losing muscle mass and tone, and is their overall health being affected because of their joint pain. So I don't routinely set an age range, but we want to maximize the amount of time to surgery. But that's a one-on-one conversation with your surgeon. It's certainly something to bring up if you're a younger individual suffering with joint pain. Beth asked, are there PT goals during total knee replacement? Like I said, physical therapy after knee replacement surgery is very, very important because, again, it is a little bit more difficult to recover during your rehabilitation after knee replacement, mainly because we got to work on straightening the knee and keeping the knee bent up to a functional range of motion, which is anywhere from 110 to 130 degrees. So as far as your goals, we want to mobilize you quickly to allow for early increased function, but we don't want to do it too quickly and cause pain and swelling. So routinely after a knee replacement, you'll start off on a walker for a few days to weeks. You'll transition to a cane, and during those first 2 to 6 weeks, you will be doing either home or outpatient physical therapy to work aggressively on strengthening your quadriceps and your hamstring muscles, as well as your range of motion of your knee. If you can get to a point 6 weeks postoperatively where you're nice and strong, you're independently ambulating, and your knee is bending up to those range of motion goals, routinely you should have a really good result. Are there any other questions coming through the live feed or anybody that's sending them directly to our website or our Facebook link? Okay, well, thank you all for joining us tonight. Certainly happy to talk to you guys about hip and knee replacement surgery and a lot of the questions that entail. Sorry, we had one last question pop in there. Actually, two very good questions that I'll address. So I'll give it a little bit more time before we close out. Sharon had asked, how soon can you drive after a hip replacement? Routinely, after a hip replacement and driving takes about 2 weeks at the earliest for a left-sided joint replacement. You have to be off your narcotic medication as well as being able to safely get in and out of your vehicle. With right-sided total joint replacement, it's up to your surgeon, but it can vary anywhere from 2 to 6 weeks depending on preferences. And finally, Sue Ravorda asked, is recovery easy with iovera? This is something that we certainly have the capability to use in our office, and it's a nice technology as far as limiting narcotic use after joint replacement surgery for up to 80 to 90 days. Is recovery easier? It depends on how you respond to the iovera, and as long as it's effective, we can reduce your narcotic consumption and then limit your pain during your rehabilitation to allow you to fully recover from the knee replacement. So if that's something you have further questions about, we can certainly discuss that with you during your office visit. All right, well, again, thank you all for tuning in tonight. If you have any further questions or follow-up questions, you can ask them through our website, and I'd be happy to answer them for you. Obviously, if you're suffering with hip or knee pain, we have multiple locations at OSMS in Green Bay, now the Fox Valley and Wapaka, amongst other Northeast Wisconsin locations where we'd be happy to see you and discuss further your hip or knee pain at that time. Have a good night.